on Zoom, where we cover a variety of health topics. So if you're interested in receiving any more information about our upcoming Deaf Health Talks, please sign up to our MailChimp, which is a listserv in which we'll post down below in the chat box. And you can receive our monthly updates and emails with updates about our new Deaf Health Talks. The Deaf Health Talks are also possible through the efforts of many people in different organizations, including the University of Michigan Department of Family Medicine, the MDisability program, Partners in Deaf Health, and Michigan Medicine Interpreter Services. This event is captioned, and we encourage you all to ask our presenter questions using the Q&A function down at the bottom of your screen, and we will have a dedicated question and answer portion towards the end of the talk for around 20 minutes. Without further ado, I would like to introduce our presenter for this evening, Dr. Ian DeAndre Lazarus. Dr. DeAndre Lazarus is entering his final year of medical school at the University of Rochester School of Medicine and Dentistry. He received his master's in public health and his PhD in translational biomedical science with a concentration in cognitive neuroscience from the University of Rochester School of Medicine and Dentistry. He's also the co-founder of Deaf and Scrubs, which is a social media channel that explains medical concepts in American Sign Language. He's passionate about medical education and making medicine more accessible to the deaf community, and the use of wearable augmented reality, AR technology, within the medical settings. And with that, I will hand it over to you, Ian.
Thank you for that kind introduction. I'll be speaking about stroke today, and let me just pull up my slides. One moment, please. So this is how I sign stroke. Other people sign it this way, and that's not one that I really like because it gives the same kind of meaning as concussion. It kind of looks like concussion, like a football player's brain hitting the side of his skull when he hits something like the ground really hard. And strokes are signed like this, and there's a reason for that I'll touch on in the next few slides. So I have found that sign, the one about the open hand down the middle, is the one that best encapsulates the meaning of it. When we talk about stroke, we talk about acting fast, F-A-S-T, and I'll be speaking to what that means too. So we'll start with a simple definition of stroke. A stroke happens anytime your brain, well, I should start by saying your brain needs blood flow. Blood flow goes from your heart to your brain, and that's how you get oxygen. You breathe in oxygen, goes into your blood, and then the blood then travels to your brain carrying that oxygen and delivering it to the brain. It's essentially like brain food. Now, if something were to happen that would cause your oxygen to not get to the brain, certain areas of the brain, if you don't have enough blood, people can die or symptoms can occur that may lead to death. And so usually the symptoms kind of depend on where in the brain a stroke happens. So strokes can cause brain damage. They can cause disability or death. Some folks can even recover fully depending on how long it's been since your brain has had the oxygen that it's recently lost. And like I said, it depends on where in the brain you have a stroke. If, for example, you have a stroke in the part of your brain that's responsible to keep you breathing, that may be a lot more dangerous. Or perhaps you have a stroke in the area of your brain that is responsible for muscle coordination, and you have a stroke while you're driving. So if you happen upon someone that you think might be having a stroke, you can call 911 because it is so time important. We recommend that you do, because the longer your brain goes without that food, without the oxygen, the more damage that happens in that space of the brain, and the harder it is for you to recover. So time is truly of the essence. Not all strokes are the same. And so they come in different flavors. There's three major strokes. There's hemorrhagic stroke, which is anytime there's active bleeding in your brain. So your brain has vessels that kind of go all around it. And if one of those vessels were to burst and start openly bleeding in the brain, and that can happen outside of the brain or within the brain matter. And both of those two have separate effects on the brain. It can affect how your body moves. It can affect the pressure within your brain. It can increase the amount of pressure that's pushing on your brain because of the skull. And that increased pressure where the brain is bleeding and has nowhere to go, because again, that skull is hard. The brain only has so much space to bleed and move and grow and swell before something happens. So it can affect certain parts of your brain. While some strokes only affect certain parts of your brain where it bleeds or where you don't have oxygen, hemorrhagic strokes can be really concerning because while it may only be in one part of the brain, the increased pressure of all that blood filling the skull can then cause issues in other parts of the brain, even if they are well perfused. The second type of stroke are called ischemic strokes. Ischemic stroke is not an active bleed, but rather the lack thereof. If there's a blood vessel that's occluded or clotted or can't allow blood through it, whatever tissue is downstream of that blood vessel is not going to get oxygen, and those tissues will die. And so depending on where in the brain that lack of oxygen happens, you will see symptoms in certain part of your body. We have the carotid arteries, which are the two major arteries that feed into the brain. If there's a blockage or an occlusion in the carotid artery, then the entire brain is not being perfused. The entire brain does not have oxygen. Now, if the carotid artery is perfectly wide open, it's flowing blood, having no issues at all, but somewhere up downstream in the brain, in one of those little vessels that feeds a certain part of your brain, if that little spot is occluded or closed off and blood can't get through, the tissue in that specific area will become affected. And again, the symptoms depend on where it is that you have this blockage. If it's on the left side of your brain, for example, you would see symptoms on your right side. So if you have a blood clot on the right side of your brain, you might have a left arm that is drooping and numb and tingling when the other side of your body is perfectly fine. Or maybe if you have a blocked vessel on the right side of your brain and all of a sudden you have a facial droop on the left side. So it's always on the opposite side. And that's why I use this sign for stroke, is because it impacts one half of the body or the other. Ischemic strokes are the most common types of stroke. They make up for about 70% of strokes in general. And what you see with ischemic strokes are sudden changes in sensation, where suddenly you can't feel your hand and you can't even pick up your arm. It's just came out of nowhere. That's an ischemic stroke. You also notice that folks having ischemic strokes will be confused. They'll have some vision changes. For example, they'll only be able to see half of what they usually see. So they can see the right side, but all of a sudden, everything in the left side of their visual field is gone. And again, depending on which side of the brain has the blockage, the opposite side of your visual field will disappear. So again, it depends. It may be your vision, it may be your numbness and tingling in the arm, it may be a leg, it may be a facial droop. That's all dependent upon which side of the brain you have the stroke on and where. The last type of stroke is called TIAs, or transient ischemic attacks. Transient meaning they're short-lived. Ischemic meaning there was no blood flow. And attack A. So that means essentially it was a mini stroke. At some point there was a blockage that was short-lived and somehow resolved spontaneously on its own. So that may look like numbness and tingling in an arm that suddenly went away after a little bit. And TIAs can be really dangerous because people will go numb and then the feeling will come back and then they'll think nothing of it. But what that means is likely these folks are going to have another mini stroke or a massive stroke later in the future. Because if they have a transient ischemic attack or a transient stroke, what that could be caused by is an artery that's actually narrowed or partially blocked. And if they disregard those symptoms thinking that it's nothing, those arteries can be worse affected later. I want to go back to hemorrhagic stroke for just a moment, because I wanted to add that often you will see people saying they're having the worst headache of their life, or they're really, really dizzy out of nowhere. They may feel nauseous and they may even vomit. Those are all really strong indicators of a hemorrhagic or a bleeding stroke in the brain. You'll see that massive, massive headache. So I mentioned in the beginning that there's an acronym FAST to keep in mind. The F stands for face. As I mentioned before, half of the face will have a droop, may have a droop. You'll see one eye kind of staying open or entirely closed, again, depending on where the blockage is in the brain. When you ask someone who's having a stroke to smile, you may notice that they smile, but only on one side of the face. The lip doesn't move on the other one. And that is pretty drastic. You can usually identify that symptom pretty quickly. The next is A for arms. If you notice that a person's arms aren't functioning the way they usually do, what you can do if you're wondering if someone is having a stroke and you're concerned is just tell them to lift up their arms. And if they can do both of them at the same time with no effort at all, then it's unlikely to be a stroke. But if they struggle to lift one arm or the other, then that's indicative that it very well may be a stroke. Moving on to sign and speech, which makes up for the S in FAST. You may notice that people are signing in a way that is slurred. And again, because of the arm weakness, that does come up. If all of a sudden people maybe look like almost like they forgot how to use their hands, or they're saying something that's completely unintelligible when they're usually someone that you understand very well, that may be an indicator. Or even sometimes where someone is saying something that the words or signs are totally normal, but don't make sense in that sequence, or they put a bunch of signs together that don't make sense. Lastly, T stands for time. If you see symptoms in the face, arms, and in the sign and speech, what you want to do is call 911. Send them to the hospital. Time is of the essence, and I will speak on that shortly. So let's say someone in your presence calls 911. They're brought by ambulance to the hospital, or the ambulance is taking too long and you decide to drive them yourself, carefully, of course. You arrive to the hospital. Obviously, that's what you're going to want to do. We would, of course, rather than an ambulance take them, but however they get there, they get there. What's going to happen, what is going to happen with this patient or this person is that a stroke alert will be called, and then a team of neurologists and neurosurgeons will be called by the emergency department physicians to come and evaluate this person. They'll look the patient over and determine whether or not they need imaging. And the imaging that's best is called a CT, and they're placed in a CT scanner, which provides a really fast, essentially, read on your brain to see if there's blood in the brain, if it's perfusing, and that separates out those who may be having a hemorrhagic or actively bleeding stroke versus those who may be having an ischemic stroke in which they're not getting blood and oxygen to their brain. And that determines what treatment is given to each patient. Sometimes people will see nothing. Providers will do the CT and see nothing. And it may end up being something that isn't a stroke. That does happen. But what's really important is that physicians rule that out. While they're getting ready to do a CT, what they'll do is a quick neuro exam. They'll ask a bunch of questions. They'll ask the patient's name, their birth date. They'll ask the patient if they know where they are, what year it is. And what they're doing is trying to get a sense of what that person knows and what they don't know. Can they lift their arms? Can they lift their legs? Are their eyes reacting to light? That essentially provides some insight to the neurologists about where it is that a stroke may be happening in the brain. That happens on the way to the CT scanner, which then takes 5 to 10 minutes. And the neurologists and neurosurgeons will be sitting in the back, kind of reading on the computers what the results of the CT are, and then determine from there. What they're going to do often is ask when you were last known well. And what that means is, what time were you last behaving yourself? What time were you last able to lift your arm? What time did you notice that your face started drooping? Because timing since last known well really determines treatment. So if a patient has a facial droop, you would ask, when did that start? And the time that has elapsed since the onset of symptoms determines treatment. If someone were to wake up with symptoms, for example, they would have no idea what time their last known well was because they were sleeping overnight. And so the last known well then would be, when was the last time you were awake with no symptoms? So they would base it off of whenever that person went to bed, as long as they had no symptoms. And the reason they need to know a patient's last known well is because if a patient has an ischemic stroke where they don't have enough oxygenated blood to the brain, they have to give you less than 4.5, there has to be less than 4.5 hours since your last known well to treat an ischemic stroke. If more than 4.5 hours have passed, then any treatment or medications won't work, which means that whoever it is that sustained the ischemic stroke may have more damage in the future. The goal of the medication, if a person is eligible for it, is to essentially bust open the clot to restore blood flow. The problem is that this type of medication can then cause bleeding in other parts of the body. Now, if it's been less than 4.5 hours, it's more likely to be worth the risk than for someone who is maybe 8 hours past the last known well, in which case it's less likely to bust a clot and more likely to cause bleeding, perhaps elsewhere. So that's generally one big piece of information that neurologists will want to know. They'll also want to know if someone has any bleeding disorders, because that will also impact whether or not they give this type of medication. For those who have other diseases or who have diabetes, are over 80 years old, the threshold for those folks is usually closer to 3 hours. So anyone who takes blood thinners is another person who's far more likely to bleed as a result of this medication. And so again, the threshold is lower. If it is an extremely severe stroke that impacts the entirety of the brain, it's also going to be a lower threshold of 3 hours as opposed to 4.5. And then, of course, if you have a hemorrhagic stroke, they're not going to give you this medication because the medication is intended to bust open a clot and make you bleed more. And if you're having a hemorrhagic stroke, that's the last thing they would want. So it's important to remember that there's different treatments based on what type of stroke it is. Next, we'll talk about treatment and how to treat ischemic strokes versus hemorrhagic and TIAs. So for ischemic strokes, I just mentioned the clot busting medication that's called TPA or TNK. Some hospitals use one, others use the other. TPA has been known to be pretty risky, but certainly worth use. TNK has been found to be a little bit less concerning, and so a lot more hospitals are kind of adopting TNK. Our hospital, for example, has made that transition. Some people call TNK TPA, even if they mean TNK. But what matters is that the medications are essentially the same in function or in purpose, and that is to loosen up any blood clot that may be causing a blockage, to clear that block so that your brain can get oxygen again and heal. For hemorrhagic strokes, the treatment for those bleeds are not obviously to make you bleed more, but instead to look at the imaging and to determine whether or not this patient would be eligible for surgery. So what neurosurgeons will do is they'll measure the amount of blood. If it's a small amount of blood, they'll leave it and allow the brain to clean it up, reabsorb it, redistribute it, and heal on its own. If it's enough blood that it's causing an increase of pressure on the brain, again, because that skull is only so big, they may go into the brain, bring you into surgery, go into the brain and create a hole so that there's some place for the blood to go. And once that blood comes out of the skull, all of a sudden the brain can kind of flex and breathe again. And that's another way that healing can happen. If it's a massive hemorrhagic stroke, what they'll do is they will essentially clean out all of the blood in the brain and find a way to stop the bleed. And again, time is of the essence, especially with these kinds of strokes, because there's only so much damage that can be repaired. They can also give you a medication to decrease your blood pressure. If someone has high blood pressure just on a day-to-day basis, they may bleed more or bleed faster. And so doctors might give you a medication to slow your heart or to lessen your blood pressure. They might give you medication to prevent a seizure, because sometimes when your brain is undergoing a lot of stress, a seizure can happen as a result. And so some anti-seizure medications are also given in the case of hemorrhagic strokes. TIAs, or transient ischemic attacks, are treated medically to reduce the chance of having another stroke. What they'll do is they will thin your blood, and not in a clot busting way like they would for an ischemic stroke, but just enough to make sure that the blood stays blood and that it doesn't clot up and become something that gums up the pipes. So they'll give you a little bit of medication that you'd stay on in order to make sure that that blood keeps flowing. Neurosurgeons may also evaluate images of your brain to determine whether or not surgery may be needed to fix some of the arteries. So the carotids, which I talked about briefly, they're the things that you can feel on your neck to determine someone's pulse. Sometimes patients will undergo an MRI or a CT. So MRI is a specific kind of CT that looks at the blood flow, and you can see the amount of blood flow through the carotid. And if the carotid is really narrowed, if you've got really high cholesterol, that essentially gums up the pipes, that gums up the plumbing and makes it harder for blood to get through. And so neurosurgeons may make the decision to bring a patient into surgery and essentially clear out that pipe, take out all of the gumming up and make that a smoother vessel so that better flow can be restored. Once a person has been treated for stroke and the blood in their brain, if it was a hemorrhagic stroke, if they've got the bleeding to stop, if it's an ischemic stroke, they've restored flow, what have you, a person's brain has been stabilized, there may still be symptoms. Those vision changes don't just go away. And so often patients will need physical therapy for a little while to help recover function if they had, let's say, a weaker arm, because the brain has to essentially reconnect with the arm. It has to reconnect all the connections it makes in order to move that arm. Some people may even see a loss in function, either completely or even just a little bit. Again, it really depends on timing. If someone has a stroke and within 10 minutes is being treated, there's a lower chance of them seeing long-term damage as opposed to someone who experiences a stroke and isn't able to come in for hours and hours. Lifestyle modifications may also be necessary because strokes can reoccur. So your food habits, your daily to-dos, your exercise, your sleep, your smoking status, these are things that you do in your day-to-day that may need to change. And if they don't, the risk of a stroke reoccurring is high. And so the recommendation, in addition to potentially medications, if a physician determines it's necessary, Other recommendations are to be sure to exercise, 2 to 3 times a week. Go out for a walk 30 minutes a day, get that blood flowing through those veins. If you have high cholesterol, that's another concern. You really want to get that into a healthy range. Some providers may have already prescribed you some cholesterol lowering medications. And what those medications do is prevent that gumming up of the pipes that I've talked about. Smoking is a really high risk for stroke. So for those who do smoke, we recommend that you try to stop. I'm not sure if anyone knew this, but smoking can actually impact surgery recovery. Once you've recovered, let's say a person has brain surgery and they're a smoker, their brain's ability to heal is massively slowed down based on the fact that their brain and their body is that of a smoker and has been impacted by cigarettes. So and for those who may be vapors, research has also shown some detrimental impacts of vaping as well. So I recommend nicotine patches, nicotine gum. I recommend that you talk to your healthcare provider about ways to quit smoking because it is really important in lowering risk of stroke. Blood pressure is also a huge risk factor. If you have high blood pressure, that increases your risk of experiencing a stroke. Because if you have high blood pressure, that means your blood is being pushed really, really hard through your veins. And that's pushing a lot on the vessels. And if you can imagine, blood being pushed fast and hard against the side of a vessel could very easily lead to a tear. One great way to lower your blood pressure is to just get some exercise. Getting that heart pumping makes a huge difference. A patient that presents to the hospital with potentially a stroke, what they will do is hook you up to an EKG to determine whether or not the stroke came from the heart. There are ways to prevent strokes. There are some high-risk things that you can avoid, like high blood pressure, high cholesterol, diabetes, heart disease. These are all things that are associated with a higher risk of stroke. And to decrease your risk of having any of these illnesses, it's important that you eat a balanced diet. Try to avoid the junk food as much as you can. For folks who like to pop in for fast food every day, try to avoid it. Only go every so often if you can. I know it's tempting. It tastes amazing, I know, but it's really important for your health. I mean, imagine if a stroke were to happen today, the impact on the rest of your life. It's important to have a balanced diet. Have your fruits, have your vegetables, get your proteins. That is really, really important. Exercise frequently is also really important. Take the time, maybe go for a 20-minute walk. A healthy weight is also helpful. So make sure that you have, and that doesn't mean you have to be a bodybuilder or a model. It just means that you should be able to walk without being short of breath. If you are, then that's considered high risk. So try to be mindful of your weight so that you're not feeling like you're exhausted by a flight of stairs. Alcohol can also impact your risk of stroke. So try to limit that as much as you can. Too much alcohol can certainly affect how the blood moves through your body. It can affect how your heart functions. So try to minimize the alcohol intake. And then lastly, as I emphasized before, quit smoking if you do, because that also has a massive impact. So in summary, strokes are a serious medical emergency that require immediate attention. Time is of the essence. You want to make it to the hospital as soon as possible. Now that you know what the signs of a stroke are, FAST, the facial droop, the arm droop, the slurred speech and sign, make sure to call. And if you're not sure, again, just have someone, if someone is in your presence and might be having a stroke, just have them lift their arms up. If you notice someone signing things that don't make sense or signing completely unclearly and you're concerned, call 911. Remember that there's a 3-hour or a 4.5-hour threshold. And if it's less than that, a person can be treated. If it's greater than that, may not be likely. And lastly, lifestyle changes can minimize the risk of stroke. Quit smoking, live a healthy lifestyle, and start now. I mean, you could live a healthy lifestyle and still have a stroke, but your chances are much, much lower. Go to your annual exams with your providers. Make sure that you get your checkups, get your blood work done. Now, what's important to know about strokes is that they come after a cumulative amount of things. You may eat junk food, and that may not do anything to you right now, but 30 years of eating junk food certainly may give you a lifetime's worth of high cholesterol, which then in turn puts you at much higher risk for clotted arteries and therefore an ischemic stroke. And so let's say you smoke, if you quit smoking today, imagine the benefit in decreased stroke risk 30 years from now. And that's it. And now I'm open for questions.
All right. Thank you so much for all of that amazing information. I know it's going to help a lot of our viewers and our future viewers, learn more about how to identify a stroke and what to do in the case that they themselves have a stroke or one of their loved ones has a stroke. So we actually have a lot of questions coming in. So I'm going to start off with our first one. And it's asking, can you talk about the effect on language in deaf patients if there's an ischemic stroke impacting the language center in the brain? What will that look like or feel like?
That is a great question. So it certainly is impacted, communication that is. There's a part of your brain that's associated with language, but there are a few different parts. There's one part that has to do with your ability to move your arms and your face. For hearing people or those who speak and don't sign, these muscles and the mouth, the neck and the mouth, are used to communicate. And so if a stroke impacts those muscles, they can't speak clearly. But there's also another part of the brain that's responsible for comprehending and expressing things in language. So if you have a thought and you want to sign it, if that area of the brain experiences a stroke, you suddenly will not be able to understand other people. Things that you're saying, things that other people are saying to you suddenly don't make any sense. And if that area of the brain is affected, it can also look like a person signing things that don't make any sense. And for the person signing who's having the stroke, they may feel like they're making perfect sense. And they don't understand why their friend doesn't understand what they're saying. Sometimes the signs in and of themselves make sense, but the sequence or the sentence doesn't make sense. So instead of saying, I'm going home, they'll sign tree, car, black. And they'll be confused that whoever it is didn't understand that what they actually said was, I'm going home. So again, it depends on where in the language center of the brain the stroke happens, but there certainly is an impact.
That's really interesting to hear. Thank you for answering that question. Our next question is asking, could social engagement ameliorate the lingering effects after a stroke?
Social engagement is always helpful. Anytime you're socially engaged, you're connecting with people. That's always helpful. If you're isolated and you're not interacting with others, there's a higher chance of things like depression and struggling to take care of yourself and getting support. Support systems are really key during healing and recovery. Others can help you and maybe help people be more motivated to move their bodies and relearn some skills that may have been lost as a result of the stroke. If an arm is weakened, for example, and it's a deaf person or a signer, engaging with other people would force them to use that arm. That just the very fact of interacting with other people is a practice of reconnecting the brain to the arm muscles. And so, yes, I think social engagement is really helpful in recovery.
All right. Our next question is asking, regenerative therapies are on the rise. Do you anticipate that we will one day have a regenerative therapy that reverses the effects of an ischemic stroke?
That is a great question. I am hopeful. There's a lot of progress and research in that area right now, just regenerative therapies in general. The use of stem cells, for example, is on the rise. And what that means is, your brain, since it began forming, has one type of cell that is one of the few cells that can't be replaced. It doesn't undergo this process where the old one dies and the new one is made. It just doesn't replace itself. It works around loss. It may try to develop new connections with what is left, but the cell in and of itself does not recover. And so the idea is how to figure out how to get these cells back to a place where they were almost like babies, where they could just do about anything. And we're not quite there yet, but I think probably in the next 10 to 15 years, we may start seeing a lot more progress in that area, especially related to spine injuries. There's a lot of research in that realm right now with regards to folks who sustain a spinal cord injury in how to relearn walking. Anytime a person loses control of their legs due to a disconnect in the spinal cord, their current regenerative medicine aims to essentially reestablish that connection. And of course, in the brain, those connections are a little bit more nuanced and confusing and challenging to address as compared to the spinal cord. But yes, I think and hope that regenerative medicine can be a solution in reversing impacts of a stroke.
All right, our next question is actually about coffee, and it's about if coffee is good for the heart, and is it bad in terms of could it increase the risk of potentially getting a stroke?
That is a great question. I have to admit, I love coffee, so I'm a little biased, but coffee has its benefits, certainly, but it can have some risks as well. It can increase anxiety if you drink too much. It may increase your blood pressure. I recommend that people see this on an individual basis and kind of talk to your respective physicians about what you think is best for you, because I can't really make a global statement or a global recommendation. I do think that coffee in general in small doses is fine, but again, it depends on your own bodies, and I recommend that you talk to your family physician about that.
All right, our next question is, what heart rate and blood pressure is considered to be a higher risk of developing a stroke?
Another good question. A healthy blood pressure would be under 140. So you know how blood pressure will usually have one number over another, like 120 over 80? The top number is the most important one. That's called your systolic blood pressure. The bottom number is called the diastolic blood pressure. And what matters, the goal for a healthy heart is to have a systolic blood pressure, which is the part of the number that indicates your blood squeezing and pushing blood. The goal is to have that number under 140. If it's over 140, it's recommended generally that folks over 140 take medication. But research shows that 140, even 140 may be too high of a number, and that 130 or 135 systolic is likely a more appropriate threshold. And as you go up to the 160s or even over 200, the risk and concern for stroke astronomically increases. If someone with blood pressure at 165, 170 all of a sudden doesn't feel good, feels nauseous, has a headache, I would strongly recommend that they go to the emergency department or see their physician. But the goal is 140 and under. And then for heart rate, usually it depends. It can be anywhere from 60. Some folks, if they're a really athletic individual, they're young, they work out, they can have a heart rate as low as 50, but usually the average person's heart rate is between 60 and 80 if they're sitting down. A person who's walking, of course, will see a higher heart rate. But if you're sitting, not doing anything, and the heart rate is really high, perhaps over 100, that is considered concerning. The goal is to have it generally under 100.
And after you have a stroke, are you at a higher risk for other health issues or developing other health conditions?
Yes. Well, for starters, you have an increased risk of a stroke occurring again. There's an increased risk of other diseases that are secondary to the stroke. So for example, if a stroke leads to a loss of function in your arm or your legs or half of your face, especially if it's a hemorrhagic stroke, that means that you may not go out, you may not be able to travel, you may not be able to get around town, you may gain weight, you may develop heart problems in the future, you may eat less in less healthy ways. So a stroke can really impact every aspect of your life, and those aspects of your life can in turn lead to other diseases. Yes.
All right. Our next question is asking, how can hearing or non-signing medical professionals communicate with a stroke patient who only uses ASL to communicate? Should they call for an ASL interpreter? And also, how can they mitigate some of the communication barriers that are due to stroke, as well as the language barriers due to ASL use?
Sure. Well, for starters, we need more deaf physicians. I am working to change that. I will soon be a doctor, and I would love to see more people like me. I would love to see more deaf people in medical school, because the more deaf physicians we have that are out there signing, the better care deaf patients can get. Now, if there are no signing physicians at a hospital, of course, calling an interpreter right away is really important, especially someone in person, because even video remote interpreting, VRI, is not ideal. If a stroke patient is laying down and perhaps has an inability to move their head or sit up, the VRI option doesn't really do much for them. And so it's important to bring in an interpreter. And we recommend that all physicians learn sign language, even just basic signs. If a physician knows the questions they want to ask in sign language, even if that's all they know, that gives them a lot of information. That gives them a massive clue as to what might be happening. But it's also important not to rely just on that. Physicians should also be making sure to call the interpreter first. And should the interpreter take a long time to get there, perhaps then falling back on knowing those signed questions. But it would be great to have an interpreter there to make sure that you're not signing random things. And it's also important for the physician to learn from deaf people so that they know they're signing the right things. But another challenge is how to interact with someone, a deaf person who may be struggling and might be having a stroke and they're not signing clearly. That is a huge challenge. There has to be other ways to communicate. If a deaf person who communicates through sign language doesn't have use of their arms, You can use things like blinking. You can set up blinking rules. Sometimes you have to depend on another person's account of what may have happened. And that could suffice in providing enough information for the team to determine what may have happened, even if the stroke patient themselves can't respond. So physicians just try to get as much information as they can in order to make the best decision. And in the absence of communication, the CT, that imaging is the best way for physicians to determine what the best next steps are.
All right, our next question is asking, what are some common misconceptions that the public may have about strokes?
Some people think that strokes result in a loss of function of everything. And a lot of folks think that there's no recovery after a stroke. There was a patient that I had who looked like they couldn't communicate. Their body wasn't moving. They couldn't see, and they were really freaked out. And they had restored almost all of the function in their entire body. And so, the medications really do, and the timing really do make a difference. How bodies respond to treatment for stroke really vary. And again, the best thing you can do is get in fast. So if you notice someone having some symptoms that may look like stroke, time is of the essence.
And following up on that, when seeking treatment for a stroke, how important is it to go to a comprehensive stroke center versus a primary stroke center? And could you elaborate on the differences between the two?
A comprehensive stroke center versus
Primary stroke center.
So the distinction between the two really depends. But again, time is crucial. If you have a comprehensive center that has a CT scanner, they have treatment options, and it's close by, that would be the recommendation. Obviously, if it's a stroke center, it will have everything. If there's a primary stroke center that's closest, you would want to go there, wherever, if it's an ischemic stroke, would have TPA or TNK. You want to get that treatment again within 4.5 hours or 3 hours if you're one of the high-risk populations I mentioned before.
And speaking of high risk, are strokes hereditary? And if so, how much does family history play a role in developing strokes or play a role in the risk of developing strokes?
I'm not sure if there's a clear genetic link for stroke, but the risk factors can be genetic. So high blood pressure, for example, can be genetic. Some diseases can be hereditary, like high cholesterol. That can also be familial. And while the stroke may not be familial, the condition that puts you at higher risk for the stroke would be familial. But as for the stroke itself, I'm uncertain.
Yeah, and our next question is asking about support. So, for family members, friends, or caregivers, if they notice someone having a stroke at home, what can they do to help while the ambulance is on the way?
That's a great question. Time is of the essence, as I said before. So if the ambulance is taking a while and it's not going to get there very quickly, sometimes driving your family member or your loved one to the hospital is your best chance. But again, ambulance is the safest and best bet. If you're speeding to get someone to the hospital, that's probably not the best way to go. But I'm imagining if you live in a rural area that maybe doesn't have ambulances very close by, it might be wise to figure out a way to determine whether or not it's worth waiting for an ambulance versus safely transporting a loved one there. So it's a timing as a consideration, but in most city areas and anywhere that's, fairly urban, you shouldn't have any challenges. But in the meantime, monitoring them is really important. Make sure they're in a safe space, make sure they can breathe, make sure that they have a clear and open airway. Make sure that if they're having a stroke and they're kind of passing out, make sure that they're sitting in such a way that their head is up so that air can get in and out of their pipe. You want to make sure that they have a heartbeat. So keep an eye on that pulse. If you notice that their face is turning blue or you can't find a pulse, do CPR if you know it, because that saves people's lives. It really does. Sometimes it's not clear if someone who's passed out had a stroke or not. What you can do is do your ABCs. A stands for airway, which is how you check to make sure they're breathing or make sure their airway is clear. B is for breathing. You just make sure they're breathing. And C is circulation, and that's when you check for a pulse. And if any of those are absent, CPR should be started. And that's why I recommend that everybody get CPR certified, learn how to do CPR.
Absolutely. I think that's very important to make sure that as many people are aware of CPR and how to properly perform chest compressions. I just want to remind our audience that we have a little over 5 minutes left. So if you have any last minute questions, feel free to type them in the question and answer box. But in the meantime, our next question is asking, after I have a stroke, will I be able to enjoy the quality of life that I've had prior to having a stroke? And what can I do to improve the odds of this?
Quality of life is always a big question for folks who are recovering from a stroke. Engagement in physical therapy and rehab is really important. Regaining your loss of function as much as you can, learning to walk again, requires that folks are willing to practice. That's one way to increase your chances, is to practice and engage in physical therapy and in rehab. If, let's say, you aren't able to walk again, or you aren't able to use a certain arm again, there are other ways to engage in life. But I want to revisit social connections and social and support systems as huge paramount ways to recover, to find ways to adapt to your new life, to find groups to engage in. If you were an athlete before and now you feel like you can't be an athlete, there are other ways to enjoy life. There are a lot of patients out there whose lives have changed as a result of a stroke, where they can't do things that they have enjoyed doing in the past, but they have found a love for new things that they never would have tried prior.
Yeah, our next question is asking, are there any gender-related differences for strokes with regard to symptoms, risk, or anything about kind of like the general presentation?
Question. It can impact men or women. Women are at higher risk statistically. The lifetime risk is 20 to 21% for women. And then for men, it's roughly 14 to 15%. So there is a little bit of a difference. And the causes of stroke differ. For women, there's usually heart disease. For men, the cause is usually related to the blood vessels in the heart. They're called the coronary arteries. There's something called coronary artery disease. And what that is when the vessels around the heart are they're narrowed. And so they can't pump blood as well. That's usually seen in males. Typically with women, the first sign of heart disease doesn't happen until they have a stroke. With men, it's usually pre-established that they have coronary artery disease and then wind up having a stroke later. And women have a little bit higher risk of stroke overall, as I mentioned, as compared to men. But even still, the effects of stroke don't necessarily differ between men and women. There's no increased loss of function in arms comparing males to females or anything like that.
All right, and our last question for the evening is asking, can supplements increase the risk of developing a stroke?
There's no strong evidence suggesting that there is an impact of multivitamins or other supplements increasing risk of stroke, no. But what's really important, again, is to focus on your eating habits, your lifestyle, your exercise routines, and things like that. And again, smoking, your smoking status. Quit smoking if you do, that will significantly decrease your risk of having a stroke. It is well documented, well researched, but there's no clear evidence relating the use of multivitamins with occurrence of stroke.
All right. With that question, we are going to wrap up for tonight. I want to say thank you to everyone for joining us tonight to hear about such an important topic. If you have any further questions, feel free to reach out to deafhealthtalks@gmail.com, and we will forward any questions you have on to our presenter. And if you have any questions generally about the Deaf Health Talks, please feel free to let us know. We'd be happy to send you more information and keep you in the loop about our future Deaf Health Talks. Our next Deaf Health Talk will be in May, and we will be sending out more information about that. So if you haven't followed our social media, please go and do that, and you will be up to date on any new information we have. And last but not least, I just want to say thank you to everyone who's made this event possible. Our presenter, Ian, you did an amazing job. We thank you so much for being here tonight. Chris, our interpreter, Kate, our captionist, and Pavani behind the scenes, making sure everything is running really well. With that, I just want to say good night and take care, everyone.
Good night. Thank you very much.